It's time for another warm-up. Let's get going. First question here, a deficiency of which vitamin results in gum bleeding, bruising, anemia, and poor wound healing? So this is going to be classic scurvy, which is vitamin C deficiency. Next, what disorder is associated with each of the following findings? So we have hypertension, hypokalemia, metabolic alkalosis, that's going to be hyperaldosteronism. Fever, night sweats, weight loss, these are your B symptoms of lymphoma, maybe tuberculosis. Adrenal hemorrhage due to meningococcemia, that's going to be Waterhouse-Friderichsen syndrome, which leads to adrenal insufficiency. Blue sclera, that's going to be seen with osteogenesis imperfecta. Hyperphagia, hypersexuality, hyperorality, and hyperdocility, that's going to be Kluver-Bucy syndrome, which is a bilateral amygdala lesion. Nystagmus, intention tremor, scanning speech, so that's going to be the Charcot triad of multiple sclerosis. Lower extremity purpura, arthralgias, and renal disease, that's going to be Haydock-Scholin purpura, which is a type of vasculitis. All right, guys, that brings us to the end of our warm-up. Let's get to that lecture.
This is our last video on anemia. Now, we've been categorizing the various causes of anemia based on the size of the red cells. We talked about microcytic anemias and macrocytic anemias, and we said that normocytic anemias could be further split into the hemolytic anemias and the non-hemolytic anemias. So in this video, we're just going to talk about causes of hemolytic anemia. Now, there are a couple of different ways you can think about hemolytic anemias. You can talk about whether the hemolysis is due to something intrinsic to the red cells themselves, such as sickle cell disease or G6PD deficiency, or whether there's something pathological going on outside the red cells, and we call that an extrinsic problem. Or you can look at where the hemolysis takes place. Is this intravascular hemolysis, where the cells are being destroyed within the vessels themselves? Or is this an extravascular hemolysis, where the red cells are being removed from circulation and then lysed, maybe by the spleen? Now, neither of these divisions is the absolute right way to do it, but it provides a convenient framework for understanding hemolytic anemia and to start to see some similarities between these diseases. So, intravascular hemolysis will lead to decreased serum haptoglobin. Haptoglobin is a circulating protein that binds up free hemoglobin in the blood so that it can be recycled. So, if there's massive intravascular hemolysis and you release a bunch of hemoglobin all at once, the circulating haptoglobin will bind to the hemoglobin, and the free haptoglobin will decrease. So that could be a useful test to order. Another lab you'll often see with hemolysis is an elevated LDH, or lactate dehydrogenase. And we talked about LDH in biochem as the enzyme that converts pyruvate to lactate and back again. So red cells have a lot of LDH, and so do cardiac myocytes. When those cells are damaged, LDH is released into the blood. So high LDH is often seen with hemolysis, but LDH can be elevated in both intravascular and extravascular hemolysis, so it's not necessarily very helpful. And what about bilirubin? Remember, hemoglobin is broken down into bilirubin. So if you have intravascular hemolysis, you would expect haptoglobin to bind up all that hemoglobin before it got broken down. But elevated unconjugated or indirect bilirubin could indicate extravascular hemolysis, and that can lead to some jaundice. So what kinds of things might cause intravascular hemolysis? Well, autoimmune hemolytic anemia is an important one. We're going to talk about that in detail in a moment. Back in immunology, we talked about paroxysmal nocturnal hemoglobinuria, which is generally pretty rare. You can also see intravascular hemolysis due to mechanical destruction of red cells. So this is a good example of an extrinsic cause of hemolysis. The red cells are perfectly normal, but something extrinsic to the red cells is causing them to be destroyed. So if you have aortic stenosis and a lot of turbulence that results from that, that can tear up red cells. Or prosthetic valves can crush some of the red cells. And then what diseases cause extravascular hemolysis? Well, there's hereditary spherocytosis. In that case, the spleen is going to recognize these abnormal, dysfunctional cells. Those cells are going to get pulled out of circulation and then destroyed by macrophages in the spleen. Extravascular hemolysis is also seen in G6PD deficiency, where the red cells are sensitive to oxidative damage. That's actually going to cause both extravascular and intravascular hemolysis. Pyruvate kinase deficiency causes extravascular hemolysis, and so do sickle cell disease and hemoglobin C disease. So let's dive in and look at some of these more closely. We're going to start with the intrinsic hemolytic anemias, or sometimes they're called intracorpuscular hemolytic anemias. Again, there's something inherently wrong with the red cells themselves that makes them more prone to hemolysis. I mean, hemolysis is sort of an occupational hazard for red cells, but on average, we said that red cells tend to survive around 120 days. But if the red cells are defective so that they only survive 90 days or 60 days or 45 days or whatever, that's going to present as anemia because there's a limit to how fast the marrow can produce replacement red cells. So one intrinsic cause of hemolytic anemia is hereditary spherocytosis. This is a defect of the proteins that interact with the red blood cell membrane and the cytoskeleton, mainly ankyrin and spectrin. We said earlier that spectrin is the protein that helps give red cells their biconcave shape, and it allows the red cells to be able to change shape slightly and squeeze through the narrow capillary beds. There are also proteins called band 3 and protein 4.2 that interact with ankyrin to link the cytoskeleton to the plasma membrane. So defects or deficiency of any of these proteins can cause hereditary spherocytosis, and the red cells are going to be shaped kind of like spheres. So on the peripheral smear, the red cells are smaller than normal and they lack the normal central pallor because, again, these are spheres instead of those normal biconcave discs. The CBC will show increased MCHC, which is the mean corpuscular hemoglobin concentration. So think about that. These cells contain the same absolute amount of hemoglobin as normal red cells, but they're somewhat smaller, so the hemoglobin in the cells is more concentrated. The RDW is also increased. That's the red cell distribution width. With hereditary spherocytosis, some of the red cells are smaller in size and some of them are larger in size. There's more variability in the size, and that variability translates to a higher RDW. That's what RDW tells you, how much variability there is in the size of the red cells. A higher RDW means a lot of variability in size, and a low RDW means that the cells are very uniform in size. Now, the reason hereditary spherocytosis causes hemolysis is that the spleen recognizes these red cells as abnormal and then removes them from circulation. So clinically, that's going to lead to splenomegaly because the spleen is working overtime, pulling all these abnormal cells out of circulation, and the spleen gets enlarged. Obviously, hemolysis will result in anemia, and the increase in circulating bilirubin could lead to some jaundice and pigmented gallstones. And then besides the hemolysis, these patients can develop aplastic crises due to parvovirus B19 infection, which suppresses the bone marrow. The classic diagnostic test for hereditary spherocytosis is called an osmotic fragility test. So you put these cells in a hypoosmotic solution, and they lyse more readily than normal cells would. So a high percentage of red cells lyse at any given concentration of sodium chloride. So red cells that would not normally lyse at a given sodium chloride concentration do lyse in a patient with hereditary spherocytosis because that normal spectrin structural framework isn't there to keep the red blood cell intact. So again, that's the osmotic fragility test. There are also newer tests that you might see as well. For instance, you can add a dye called eosin 5-maleimide to the red cells, and that's going to normally bind to the band 3 protein. So reduced binding of this dye indicates a band 3 deficiency, and that suggests a diagnosis of hereditary spherocytosis. Then the treatment is mainly supportive. You're going to give folic acid supplements, you're going to give blood transfusions as necessary for hemolysis. Patients with severe hemolysis and anemia can be treated with splenectomy. So you remove the spleen so it's not going to keep destroying the red cells. So you do a splenectomy, and then after the splenectomy, you're going to see Howell-Jolly bodies. Remember, Howell-Jolly bodies are basophilic nuclear remnants in the red cells, which are normally removed by the spleen. If there's no spleen, those red cells are going to make it into circulation. The next intrinsic cause of hemolysis is G6PD deficiency, and we talked about this in biochem. These are the patients that are sensitive to oxidative stress. So drugs that cause oxidative stress will lead to hemolysis and back pain a few days after they started the drug. Now, do you remember which drugs cause hemolysis in these patients? Let's do a little quiz. Take out a piece of paper and try to list as many of these as you can. I'll wait. Tell you what, I'll even give you a little hint. The mnemonic was spleen purges nasty inclusions from damaged cells. Ring any bells? So I want you to pause the video, try to write these down, then we'll put up the answers in a moment. Okay, here are the answers. And remember, in G6PD deficiency, you can see Heinz bodies, which are clumps of denatured hemoglobin inside the cell due to oxidation of the iron. And then the macrophages come along and remove the Heinz bodies, which leaves behind bite cells. Pyruvate kinase deficiency is another cause of intrinsic hemolysis. We mentioned this one in biochem also as a glycolytic enzyme deficiency. So with pyruvate kinase deficiency, you can't generate ATP, So you can't maintain the sodium-potassium ATPase, so you're going to get red cell swelling and hemolysis. Paroxysmal nocturnal hemoglobinuria is another cause of hemolysis, and again, we discussed this in immunology. This is where the red cells are missing the surface markers CD55 and CD59, so that complement attacks those red cells and lyses them. So do you remember what the test for PNH was? The classic test is called Heme's test, where you add some acid and you lower the pH, and that activates complement and lyses the red cells. So a positive Heme's test is where you have red cell lysis at a low pH. But that test isn't really used much anymore. Nowadays we do flow cytometry. Another important intrinsic cause of hemolysis is sickle cell disease. The hemoglobin S mutation is a single amino acid replacement in the beta globin gene on chromosome 11, in which valine is used instead of glutamic acid at position 6. We mentioned that previously. Now that mutation allows the hemoglobin to polymerize within the red cell, and those polymers stretch the red cells into that classic sickle shape. So when does this happen? What triggers sickling? Hypoxemia, dehydration, and acidosis are all important causes of sickle crisis. It's very important to maintain adequate hydration, especially during illness, to prevent sickling from taking place. About 8% of African Americans are heterozygous for the hemoglobin S mutation. We call that heterozygous state the sickle trait. And then about 0.2% are homozygous, and they have true sickle cell disease. So heterozygotes are relatively resistant to malaria. That's also true of G6PD deficiency and possibly thalassemias. Newborns with sickle cell disease are initially asymptomatic because they have more hemoglobin F. But as they get older, that hemoglobin F is replaced with hemoglobin S, and they start to have problems and complications. So they can have something called a splenic sequestration crisis, where those sickle cells are getting sequestered in the spleen. And that's going to cause the H&H to drop precipitously. So this is in infants and toddlers in the first 2 or 3 years of life. You might start to see some wedge-shaped infarcts in the spleen on CT. And then eventually the spleen is just totally infarcted by the age of 3 or 4. We call this autosplenectomy. So these patients have no functional spleen, and with that they have increased risk of infection by encapsulated organisms. So these patients need to be immunized against encapsulated organisms like meningococcus and pneumococcus. And it's a good idea to give these patients a flu vaccine every year as well. Salmonella osteomyelitis is more common in sickle cell patients. That's a classic test question. A sickle cell patient comes in with osteo. What's the organism? Salmonella. They can get aplastic crises due to parvovirus B19 infection, just like we saw with hereditary spherocytosis. These patients can have pain crises, which are due to vaso-occlusion. So the cells are sickling in the tissues and the organs. And whenever you occlude something, it becomes very painful because it's ischemic. Now this can take on different forms, like sickling in the fingers, which is called dactylitis, or something called acute chest syndrome. And then you can see renal papillary necrosis due to hypoxemia in the kidneys. In general, the renal papillae are more sensitive to this hypoxia. And then one other incidental clinical finding is that hair-on-end appearance of the X-ray of the skull from marrow hyperplasia, just like we saw with beta thalassemia. So the marrow is churning out new red cells to make up for the ones that get hemolyzed. And then how do we treat sickle cell disease? Well, we can give hydroxyurea, which is going to increase production of hemoglobin F. And ultimately, bone marrow transplantation would be definitive therapy to give new stem cells that don't have that hemoglobin S mutation. Then let's also touch on hemoglobin C disease, which is similar to sickle cell in terms of being a point mutation on the beta globin gene, but here you have a lysine substituted for glutamic acid. Now, this isn't as severe as sickle cell because those hemoglobin C molecules form hexagonal crystals in the cell instead of forming those long polymers. So you might be heterozygous for hemoglobin C, which is asymptomatic, just like sickle trait heterozygotes. Or you might be homozygous for hemoglobin C, which is milder than sickle cell disease, just a little hemolysis and a little splenomegaly, but even that's pretty rare. What you might run across is heterozygotes that have one hemoglobin S mutation and one hemoglobin C mutation. We call this SC disease. Now this is also milder than plain sickle cell disease. There are actually a whole bunch of these really rare hemoglobin mutations, but you're not likely to be tested on them. But SC disease is one you might actually see in practice. So real quick, let's take a look at how we use hemoglobin electrophoresis to diagnose sickle cell and hemoglobin C and all these different combinations. Hemoglobin is a protein, so you can put a patient's hemoglobin in an electrophoresis gel on the left and apply an electrical current, and the hemoglobin is going to migrate toward the positively charged anode from left to right on this image. So if all the hemoglobin migrates all the way to the right, that's a normal adult with all normal hemoglobin A. Neonates still have a fair amount of hemoglobin F, and hemoglobin F is slightly more positively charged. so it doesn't migrate quite as far to the right. So in a neonate, you see a band for hemoglobin A and a band for hemoglobin F. Now, hemoglobin S in a sickle cell patient is even more positive because you've replaced a negatively charged glutamine residue with a neutral valine residue. So the hemoglobin S band is even farther to the left, toward the negative terminal, the cathode. So in patients with sickle trait, you're going to see a hemoglobin A band and a hemoglobin S band. And then in patients with sickle cell disease, they're going to have essentially all hemoglobin S because they're homozygous. In the same way, hemoglobin C is more positive still because here that negative glutamine has been replaced with a positively charged lysine. So the C band is even farther to the left. That means that in hemoglobin C trait, you can have an A band and a C band. In hemoglobin C disease, which is homozygous for hemoglobin C, you're going to have one big C band. And then in SC disease, you're going to have an S band and a C band. So if they give you an image of a hemoglobin electrophoresis gel on your exam, you need to know the order of these bands, and then by figuring out which bands the patient's hemoglobin migrates to, you can figure out the genotype and make a diagnosis. Next, let's talk about the extrinsic or extracorpuscular hemolytic anemias. Again, it's called extrinsic because it's something outside the red cell that's causing the hemolysis. We're going to breeze through some of these pretty quickly and then spend the bulk of our time on autoimmune hemolytic anemia, which is something you're probably going to be tested on. The first extrinsic cause of hemolysis is called microangiopathic anemia. This is where the red cells are mechanically damaged as they pass through the lumen of an obstructed or narrowed blood vessel, like in DIC or TTP-HUS, possibly in lupus or malignant hypertension. I mentioned this when we talked about schistocytes. This is mechanical destruction of red blood cells. Basically, you force the red blood cell to be chopped up by fibrin strands, or in the case of malignant hypertension, by extreme shear forces. So again, schistocytes are just red cells that have been sliced and diced. Then macroangiopathic anemia is where instead of red cells getting chewed up by microvascular conditions, here you have damage to the cells by forces in larger vessels. So we said that prosthetic heart valves can do this, or maybe rarely aortic stenosis can do this. And then there are some infections of the red cells that can cause hemolysis, like malaria or babesiosis. These are covered in the microbiology lecture on protozoal diseases. Then finally, we're ready to discuss autoimmune hemolytic anemia, which means that autoantibodies are binding to the red cells and causing cell lysis. So we divide these autoantibodies into warm agglutinins and cold agglutinins. Warm agglutinins are IgG antibodies that attach to the red cells and cause them to clump together, or agglutinate. Now you can see this with lots of different diseases like lupus and CLL, and lots of different drugs will induce warm agglutinins. And cold agglutinins are IgM antibodies, and they do the same thing, but the difference is they only cause problems when the temperature is lower, so it happens in the cold. Now, one way to remember that cold agglutinins are IgM antibodies is to remember that IgM forms pentamers in circulation, which kind of resemble snowflakes. Let's take a look at the study guide. Cold agglutinins are antibodies against red blood cells that interact more strongly at low temperatures than at high temperatures. They're nearly always IgM antibodies, and they occur regularly in infections with EBV, or infectious mononucleosis, or mycoplasma, and then also some malignancies such as CLL. So CLL can potentially cause warm or cold agglutinins. Problems occur when there's circulation to a cold extremity. IgM binds the red cell antigen, which leads to complement fixation, and then a membrane attack complex lyses the cell. Warm agglutinins are slightly different. It's also autoimmune, but it's a different antibody. These are antibodies that react against red cell antigens at body temperature. So this can happen spontaneously without needing a cold environment. The second bullet says these are nearly always IgG, and these are seen in four main things. Viruses, such as Epstein-Barr virus and also HIV can do this. So again, EBV can cause either warm or cold agglutinins, just like CLL. Lupus is the second one. The third one is malignancies. So again, CLL, but also non-Hodgkin lymphoma can sometimes cause warm agglutinins. And then the fourth one is congenital immune abnormalities. Then the next question explains the Coombs test. Autoimmune hemolytic anemias will usually have a positive Coombs test. So what's a Coombs test? A positive Coombs test is when there's red cell agglutination that occurs when you add anti-human antibody, because the red cells are coated with either immunoglobulin or complement protein. So basically, the Coombs test is a test looking for antibodies to red blood cells. The direct Coombs test is where prepared antibodies are added to the patient's red blood cells, and then these prepared antibodies are going to bind to antibodies that are on the red blood cells. So you're using an antibody to detect an antibody that's already bound to the red blood cell. If this patient has an autoimmune hemolytic anemia, the red cells are coated with autoantibodies and possibly the complement C3. So you add something called Coombs reagent, which is also called Coombs antiglobulin or anti-human antiglobulin. Basically, Coombs reagent is made of these anti-human antibodies and antibodies that bind human immunoglobulins. Or you can use a type of Coombs reagent which binds to C3. So when you add Coombs reagent, it'll bind to the antibodies and complement on the patient's red cells and cross-link the patient's red cells so that the red cells agglutinate or clump together. So a direct Coombs test is testing for immunoglobulins that are already present on the patient's red cells. We use a direct Coombs test to diagnose hemolytic disease of the newborn, or drug-induced autoimmune hemolytic anemia, and also hemolytic transfusion reactions. Now, the indirect Coombs test is a slightly different test, where the patient's serum is incubated with normal red cells to detect the presence of antibodies. So basically, you're not looking at the patient's red cells this time, you're looking at the patient's serum to see if the serum has antibodies that's going to bind to those normal red cells. So the indirect Coombs test is positive when the patient has antibodies to foreign blood. So this is used to screen blood before transfusion. So you may have heard of type and screen. That's where you take the donor blood and you screen it for the presence of antibodies with this indirect Coombs test. So you could also use this to screen maternal serum for antibodies to a fetus's red cells. So that's it for hemolytic anemia. Now it's time for the end of session quiz. So pause the video, answer those questions, then we'll go over the answers. First question. A child who's been anemic since birth has now been cured with splenectomy. What's the disease? That's hereditary spherocytosis. Next, what findings are associated with hereditary spherocytosis? You're going to see anemia, and then jaundice from the hemoglobin breaking down into bilirubin, because this is extravascular hemolysis that's taking place in the spleen. And then with all that bilirubin, you're more likely to have pigmented gallstones. You might see splenomegaly, and you also see spherocytes on the peripheral smear. You can make the diagnosis with a positive osmotic fragility test or the eosin 5 maleimide test. But Coombs test will be negative because there are no antibodies involved here. Next, what's the difference between the hemoglobin S defect and the hemoglobin C defect? So in hemoglobin S, there's a mutation of glutamic acid to valine at position 6 on the beta globin chain. With hemoglobin C, there's a mutation of glutamic acid to lysine at the same position. And remember, the charge of these different residues is important in separating these different types of hemoglobin into bands on your hemoglobin electrophoresis. Next, what's the difference between a warm agglutinin and a cold agglutinin? So warm agglutinins are typically IgG, while cold agglutinins are typically IgM. Next, what are schistocytes? Schistocytes are fragmented red cells seen on the peripheral blood smear, caused by mechanical destruction of red cells. And the last question. In what hematologic disorder will you find each of the following abnormal tests? So these aren't all hemolytic anemias, but we're lumping them all together because they're all hematologic tests and findings. So Hamm's test is the test used to diagnose paroxysmal nocturnal hemoglobinuria. Heinz bodies are seen with G6PD deficiency primarily. Basophilic stippling, you can see this with lead poisoning primarily, and then sometimes in thalassemia and anemia of chronic disease. But again, the main one to know is lead poisoning. And the osmotic fragility test is a test to diagnose hereditary spherocytosis. And then we have some rapid-fire facts. So cold temperatures lead to painful cyanosis of the fingers and toes with hemolytic anemia. That should make you think about cold autoimmune hemolytic anemia. Red urine in the morning and fragile red cells, that's paroxysmal nocturnal hemoglobinuria. Basophilic nuclear remnants in red cells. These are the Howell-Jolly bodies that you see in a patient without a functioning spleen. Autosplenectomy, you should associate that with sickle cell disease. That's where the patient autoinfarcts their spleen over several years. And then the drug used to treat sickle cell disease is hydroxyurea. Make sure you know that one. That's it for now. I'll see you next time.